Hello, my name is Dr. Felice Adler. I'm a pediatric infectious disease doctor at Harbor UCLA Medical Center in Los Angeles, California. And I was invited to speak with you about COVID-19 and antimicrobial stewardship. Thank you so much for inviting me to be here. I'm really honored to be part of your conference, and I'm so sorry I cannot be there in person, but I hope that next year I'll be able to see all of you in person and live. So again, we're going to talk about COVID-19 and antimicrobial stewardship. So I'm going to start off by talking about the pandemic, and I put the S in parentheses, as you'll see in a minute, because there may be more than one pandemic. So the COVID-19 pandemic began in December 2019, as you know, when cases of infection due to SARS-CoV-2 were first recognized. Infection quickly spread around the globe, causing about 610 million cases and 6.5 million deaths as of September of 2022. Before this pandemic, the World Health Organization had named the increase in worldwide antimicrobial resistance the invisible pandemic. So that's where the S comes from in the title of the slide. There are two pandemics, the COVID-19 pandemic, and then the pandemic of antimicrobial resistance. This second pandemic could cause an additional 10 million deaths a year by 2050 if it's not stopped. And effective antimicrobial stewardship is crucial in preventing the further emergence of antimicrobial resistance. So bacterial co-infections only occur in about 7 to 14% of all patients with COVID-19. But antibiotics are prescribed for up to 75% of all hospitalized patients in some studies. And it's this excessive or unnecessary antibiotic use that can eventually lead to antimicrobial resistance, as well as other issues. Fortunately, as you've probably seen, children develop less severe COVID-19 disease than adults, but there still have been many children that have required emergency room visits and hospitalizations. And children are still at risk for serious complications like MIS-C and long COVID. This graph shows COVID-19 associated hospitalizations among children and adolescents between 6 months and 17 years of age between March of 2020 and September of 2022. And what you can see is that even though most of the time rates of hospitalizations in children aren't particularly high, when we have spiking disease, children can have a higher rate of hospitalization, up to 16 to 18 cases per 100,000 population. Often, children that end up in the hospital are the ones that are receiving empiric antibiotic therapy. One of the first antibiotics I want to talk to you about is azithromycin, because at the beginning of the pandemic, there were a lot of children and adults that were prescribed azithromycin. In the United States, early in the pandemic, antibiotic use varied in different healthcare settings, but azithromycin prescribing was higher than expected in all settings. This includes in children. There were many studies in between the beginning of the pandemic and when this meta-analysis was done, looking at whether or not azithromycin helped patients with COVID-19. So this Cochrane review from October 2021 reviewed some of those studies, and the objective was to assess the efficacy and safety of antibiotics compared to each other, compared to no treatment, compared to standard of care alone, compared to placebo or any other active interventions with proven efficacy for the treatment of COVID-19 outpatients and inpatients. They, in the end, found 11 good studies to look at, and those studies had over 11,000 participants, almost all of whom were adults. And all the studies investigated azithromycin in mild, moderate, and or severe COVID-19. Azithromycin, they found, had little or no effect on all-cause mortality. It had little or no effect on clinical worsening, on hospital admissions, or clinical improvement at day 28 compared to standard of care. There was also no effect on symptom resolution at day 14. So in the end, the Cochrane review noted, as did many studies before it, that azithromycin really had no use in treatment of COVID-19. Other investigators looked for other antibiotics and the rate of use in children. And this study from this year is out of Spain, where they looked at 640 children hospitalized with COVID-19 from March 2020 to March 2021. And again, this was just published this year. Bacterial infections were found in approximately 7% of these hospitalized children with COVID-19, most of which were urinary tract and bloodstream infections. But this study did include patients with coagulase negative staph as having bloodstream infections, which probably was a contaminant. So true bacterial infections may have been even less than 77%. But 54% of patients received antibiotics. They found that patients with a higher severity of infection were more likely to receive antibiotics. Fortunately, antibiotic prescribing declined over time when it was clear that bacterial co-infection was uncommon with COVID-19. And the antibiotic use that declined the most was azithromycin, most likely because of the efficacy trials that showed that azithromycin lacked efficacy against COVID-19. And on this slide, we see a graph of that trend in antibiotic prescribing among children hospitalized with COVID-19 in the study. The blue bars represent the number of COVID-19 admissions over time from March 2020 to March 2021. The red line, as you can see here, is the prevalence of antibiotic prescribing. And you can see that over time, antibiotic prescribing declined. And the antibiotic prescribing that declined most significantly was shown in this purple line, which is the prevalence of azithromycin prescribing, which declined significantly to basically nothing over the time period of the study. So why are children receiving so much antibiotics when they're hospitalized with COVID-19, even though we know that so few of them have an infection? And I think this Venn diagram explains why. It's the overlap of physicians or clinicians having fear as well as diagnostic uncertainty. And when those two things overlap, we end up with antibiotic overuse. Diagnostic uncertainty is an example of that would be how we've been trying to avoid doing aerosol generating procedures to not spread COVID-19, or sometimes we need to conserve personal protective equipment. And so we may not be able to get the exact diagnostic specimens we need. In addition, there's diagnostic uncertainty around whether or not patients have a bacterial pneumonia or a viral pneumonia when they get admitted with COVID-19 disease. And it can be difficult to differentiate these two entities. And so we're left with some diagnostic uncertainty that may push doctors or clinicians to initiate antibiotic therapy. There's also fear on the part of clinicians, fear of maybe missing a serious infection, fear of a disease that's relatively new and that we don't know everything about it. And I would add a third item, which is lack of understanding the threat of antibiotic overprescribing. A lot of providers feel that antibiotics are a relatively benign treatment, a relatively safe treatment, and they are relatively safe, but there's still dangers with overprescribing antibiotics. And so clinicians who've never seen or had to treat a multi-drug resistant organism, or clinicians who haven't dealt with a serious case of C. difficile infection may not understand the threats of antibiotic overprescribing, and that may lead to overprescribing as well. Why do we care about overprescribing antibiotics? Well, antibiotics are a shared resource, and one meaning of this is that antibiotics are the only medication that does not just affect the person taking the medicine, but affects everyone around that person. So for example, if you took a blood pressure medicine, it would only affect your blood pressure. But if you take an antibiotic, it affects the flora or germs in your gut and on your body. And it also affects the germs and flora on everyone around you who's interacting with you and sharing germs with you. Antibiotics can be misused in hospitals. Overuse of use of antibiotics can lead to medication-related adverse events. Antibiotics can also lead to Clostridioides difficile diarrhea, and overuse of antibiotics can lead to antibiotic resistance, which is extremely important to try to get a handle on. So for all of these reasons, antibiotic stewardship is a public health imperative everywhere in the world. Health prescribers and pharmacists can improve prescribing and contribute to antimicrobial stewardship by doing these three things. So the first is optimizing antibiotic selection. What we mean by that is that when you don't use a broad spectrum antibiotic like meropenem or ceftriaxone, when a narrow spectrum antibiotic such as ampicillin or amoxicillin will do. Reassess antibiotic treatment when the results of diagnostic testing are available. So again, if you're concerned a patient may have a bloodstream infection and yet their blood cultures are negative, that would be a time to reassess whether or not you need antibiotics and potentially stop the antibiotics. And then lastly, use the shortest effective duration of therapy. So again, we're going to shorter and shorter durations of therapy these days, and don't use 2 weeks of antibiotics to treat an uncomplicated community-acquired pneumonia when 7 days is likely to be effective. In addition, empiric antibiotics are not necessary at all unless there are signs of co-infection. What are some of the tools that we can use as antimicrobial stewards? So we have dedicated personnel and resources, pharmacists that can look at charts, make sure patients are on correct medicines, make sure they're starting and stopping when they should. We can recommend radiologic imaging to help differentiate bacterial and viral pneumonias. We can have guidelines and clinical pathways that providers can follow to help choose correct antibiotics and not stay on them for too long. We can recommend rapid diagnostics and lab testing, which can help differentiate bacterial from viral infections. And we can do prospective audits on antibiotics and then give the providers intervention and feedback on how to better perform antimicrobial stewardship themselves. And lastly, we can educate the other providers that we work with and other pharmacists that we work with on how to best perform our antimicrobial stewardship. There's no one right way to use all of these tools and no one definite solution. There are still going to be people that we're not sure if they need antibiotics and they get them, and there's but we want to make sure that the right people get the right antibiotics the right way. So we use these tools to try and alleviate some of the diagnostic uncertainty and fear so that we can reduce the overprescribing of antibiotics. First, we're going to talk about inpatient stewardship with regard to COVID-19 and discuss how being an antimicrobial steward will help in this situation. So when patients come in and are admitted for a COVID-19 infection, the first thing to look at is their own clinical appearance. Do they appear septic? Do they appear very ill? Or do they appear not so ill, maybe just with a viral respiratory infection? We can ask older children to provide a sputum gram stain and culture. We can do nasal MRSA screening, which can help us know whether or not the patient is colonized with MRSA or methicillin-resistant Staph aureus, and this can help us choose our antibiotics. If the patient looks ill, we can check blood cultures as well as urinalysis, which we can send for culture if the urine's abnormal. We can do viral testing by multiplex molecular assays if available, or by single assays if not. And we can look at things like the white blood count to see if it's elevated. If the white blood count's elevated, but the patient's been on steroids, then the white blood count becomes less useful of a marker, as steroids can cause an elevated white blood count. Procalcitonin can be useful, although not as much when it's elevated, because COVID-19 infection can lead to an elevated procalcitonin. But when the procalcitonin is low, it has excellent negative predictive value, meaning if the patient has a negative procalcitonin, it's very unlikely that they have a bacterial infection. And lastly, we can look at chest imaging to help us determine what kind of infection the patient may have. So again, sometimes it can be difficult differentiating viral from bacterial pneumonia, and chest radiography can help. Bacterial pneumonia is treated with antibiotics, but viral pneumonia is not, and antibiotics will not help viral pneumonia. The most common findings in an ill hospitalized child with COVID-19 viral pneumonia includes bilateral or unilateral diffuse interstitial infiltrates, ground glass opacities, and perihilar bronchial wall thickening. And I have some examples of that on this slide. So you can see these are different children at all different ages, but what I want you to notice is like these bilateral fluffy infiltrates that are kind of all over the lung and not really focused in any one particular area. And that's pretty consistent on all of these children. As opposed to this is a child with a bacterial pneumonia, and you can see that he has very distinct lobar consolidation. If you see this, then bacterial co-infection is much more likely. When antibiotics need to be used empirically because of suspicion for a bacterial infection in a patient who's admitted with COVID-19, again, we don't need to change what we usually use for community-acquired pneumonia in children just because they have COVID-19. We can use the same medicines. So for most children greater than or equal to 6 months of age, I will say that this is data for recommendations for the United States, because in the United States, we give pneumococcal conjugate vaccine at 2, 4, and 6 months of age. So after 6 months of age, we're much less worried about patients having penicillin-resistant pneumococcal pneumonia. And so our first choice of agent to use is ampicillin or penicillin to treat susceptible pneumococcus, which is going to be the most likely cause of infection. And then there are other recommendations listed on this slide as well. Okay, this slide shows the empiric therapy that you would want to start if your patient has a more severe pneumonia and it is admitted to the hospital. And again, these are recommendations that we use in the United States, but you would want to check your local antibiogram to make sure that these antibiotics would also be active against your most common organisms that you see in patients that come in with severe community-acquired pneumonia. Again, we would use empirically ceftriaxone or cefotaxime in addition to a macrolide antibiotic. And then if you know that your patient is colonized with MRSA, or if they have a risk for MRSA, such as a family member with MRSA or prior MRSA infection, then you would want to add coverage for MRSA as well if they have severe pneumonia. But for regular community-acquired pneumonia, that would not be necessary. In conclusion, I have a slide showing what you would like to do for children with potential bacterial co-infection. So bacterial co-infection is not common in the setting of COVID-19. Antibiotic utilization should be minimized as much as possible using stewardship and diagnostic strategies. When needed, antibiotic use in patients with COVID-19 can be minimized. So patients likely do not need more than 7 days of therapy for an uncomplicated community-acquired pneumonia. If there's no MRSA isolated, then no MRSA treatment needs to be given unless the patient is critically ill or we know that they have colonized family members or are colonized themselves. And then patients can switch to oral therapy from IV therapy once they're clinically improved and taking PO. Now we're going to move on to talk a little bit about outpatient stewardship. So we're going to start with a case study of a child visiting the pediatrician's office with COVID-19. This is a 10-year-old boy with a 2-day history of fever, cough, and headache. He has no past medical history. A neighbor who he plays with tested positive for COVID-19 yesterday. Physical exam is normal except for a temperature of 101 and cervical lymphadenopathy. He has no tachypnea and his lungs sound clear, and a COVID-19 rapid antigen test is positive. The parents are concerned he may get pneumonia and they're asking if he needs antibiotics. How would you manage this patient? Would you start azithromycin? B, would you start amoxicillin? C, would you provide a clear diagnosis and counsel his parent about when antibiotics are indicated and side effects? D, would you offer recommendations for symptomatic therapy and a contingency plan for follow-up if he gets worse? Or E, would you do both C and D? And the answer, of course, is E. You would do both C and D. And why is that the correct answer? This patient appears to have a viral upper respiratory tract infection without any specific signs or symptoms that show a bacterial secondary infection or superinfection. So antibiotic treatment is not going to provide this patient any benefit and could cause harm. That's why we do not want to give this particular type of patient antibiotics. We can use some proven communication strategies, at least again, proven in the United States, and things may be different in Vietnam, to address the patient and parent concerns. So there is an organization in the United States called DART, Dialogue Around Respiratory Illnesses and Treatment, that looks at how to avoid giving antibiotics for viral respiratory infections and how to communicate that we're not going to give antibiotics and why to families. So clinicians can effectively communicate with parents and patients when antibiotics are not needed. One of the first things to do is review physical exam findings. So for example, the physician can say, I see that your child has a respiratory infection. The lungs sound completely clear, and I do not hear any evidence of pneumonia. Also, your child looks pretty well. Then you can deliver a clear diagnosis saying, I think what your child has is an upper respiratory tract infection caused by SARS-CoV-2 or COVID-19. And that infection will not respond to antibiotics. Then you can provide a two-part negative then positive recommendation. So that would go something like this. So your child does not have a bacterial infection, and so antibiotics are not going to help your child. But there are other medicines that we can give that can help your child feel more comfortable. And then you could recommend things like ibuprofen or Tylenol for fever. Lastly, or if the child's over 4 years of age, you could also recommend cold medicine for that child potentially. And then lastly, you can provide a contingency plan. And what that would look like would be something like, your child does not appear to have pneumonia now, but if the fever goes higher, if the cough gets worse, if your child looks like they're having trouble breathing, then I need to hear from you right away, or please come back for additional care. So in a patient like this, we would just recommend watchful waiting and symptom relief. The CDC, which is the Centers for Disease Control and Prevention in the United States, actually made prescriptions that are like prescriptions in quotes. So it's prescribing things that families can do that are not antibiotics, because a lot of families want to get a medicine when they come to the doctor's office. And this gives them medicines that they can take that are not antibiotics that may help and are definitely going to have less side effects and be more beneficial than antibiotics for a virus. So they say things like drink extra water and fluids, suck on ice chips or popsicles. You can use honey to relieve a cough for children who are at least 12 months of age. And then there's even a section for specific medicines like Tylenol and ibuprofen. So at least the parents can leave the office with some type of prescription, even if it's not an actual prescription. The last thing I want to address is vaccines. So antimicrobial stewardship is extremely important in preventing the development of antimicrobial resistance, as we've talked about. But are vaccines one of the tools we can use as an antimicrobial steward in preventing antimicrobial resistance? And of course, vaccines are extremely important. This slide, the next two slides kind of show how vaccines help prevent antimicrobial resistance in the population. So if a single individual who's not vaccinated gets exposed to a germ, and we can pretend, even though it doesn't look like it, we can pretend like this is pneumococcus, that person could get infected. And if the pneumococcus is resistant to penicillin, then the patient's not going to get better because of antimicrobial resistance and is going to end up seeking healthcare, potentially in the hospital, and receiving another antibiotic. When they receive that antibiotic, some patients will clear their infection, but other patients may have emergence of even more antibiotic resistance. And now they have a serious infection that's very resistant to antibiotics. At a population level, what that looks like is if the infection goes through the population and many people get both first and second line antibiotics, there are going to be many people in the population that end up with antimicrobial resistant isolates that are then allowed to spread from person to person, because really no one is protected from this germ. And that's how we get widespread antimicrobial resistance. On the other hand, if the patient is vaccinated, say against the pneumococcus, and they're exposed to infection, the disease is prevented. And in a population that's highly vaccinated, even though there might be a couple of people that aren't vaccinated, in the end, after being exposed to infection, almost everyone will be protected from that infection, and there will be herd immunity such that other people who haven't been vaccinated may be protected, and very few people will develop antimicrobial resistance. So the emergence and spread of antimicrobial resistance is mitigated by vaccination and herd immunity. So that was in bacterial infections. But vaccines can also indirectly affect antimicrobial resistance by preventing viral infections. So for example, influenza infection, as you know, can lead to superinfection like pneumonia requiring antibiotics. People with influenza get, for example, staph pneumonia. But influenza vaccine can prevent influenza infection and therefore prevent the risk of superinfection, leading to less antibiotic use. And there have, in fact, been studies showing reduction in antibiotic prescriptions ranging from 13% to 64% with influenza vaccine. So there's no reason to think that COVID-19 would be very different. We know that COVID-19 infections can also lead to superinfection. And we know that COVID-19 vaccines can prevent severe disease and hospitalization, which are two of the main conditions that are risks for superinfection. So COVID-19 vaccines will likely prevent use of antibiotics given for suspected bacterial infections as well as true bacterial superinfections. So to conclude and leave you with some parting thoughts and information to take with you, rates of bacterial co-infection with COVID-19 are relatively low, but antibiotic use is high. Judicious antibiotic use is critical to reduce the emergence of antibiotic resistance and decrease toxicity from unnecessary antibiotics. Existing antimicrobial stewardship program infrastructure for guideline development, prospective audit, and feedback can be utilized directly in pandemic relief efforts. And you can follow local guidelines, or there are international guidelines from the WHO as well. And I put the link here. We need to refine our antibiotic treatment, leveraging lab and clinical status, de-escalate antibiotic therapy if there's no evidence of a bacterial infection, educate patients that antibiotics are ineffective for viruses like COVID-19, adhere to infection prevention protocols, and finally, please make sure that all your patients are fully vaccinated, including COVID-19 vaccine, flu vaccine, pneumococcal vaccine, and all the recommended vaccines in Vietnam. Here are some additional references, and I want to thank you very much for inviting me to speak with you.
So it's okay now, yeah. And the Zoom will turn off now because it has a 40 minutes limit. And I will take the recorded video. We will download the recorded video, and it take about 10 minutes. And I will open the Zoom again after